I want to begin sort of today with just talking, both from a broad perspective and down to the more individual perspective of what the treatment options are. And looking at broadly, you can see that over here in the middle of this gray bar here, the current treatments options that are available are drug treatments and allogeneic treatments, but then there are things that are coming down into clinical trials and hopefully become available for patients in the not so distant future, in the next 5 years or so. And I just want to talk about these in context so that you guys can make a better decisions about where you are, what's available to you, and how to discuss with your doctors about this. So I want to first talk about drug treatments. And I show this because the panelists here obviously are very familiar, but also the patients and family members. You guys all been to doctors for many of the visits, and you know this pretty well. And this is just looking at just one snapshot at where the status of the patients are. Here on the left here, the hemoglobin SS, or we typically know as sickle cell anemia. And if you were to sample their blood and the blood test results, I'm highlighting just three things from those blood test results. You'll see that for a sickle patient not on any treatment, their sickle hemoglobin percentage that are within the red cells, cumulatively, is about 90% and sometimes more. The baby or the fetal hemoglobin is typically less than 2%. And the total hemoglobin levels is usually between 6 or 7%. And we know this is the typical pattern for a patient with sickle without treatment. But then when you have this patient or patients like this take hydroxyurea, which we know have been around for at least 3 decades, that hemoglobin S percentage dropped to about 60 or 70%, and that's replaced by the reactivation of this fetal or baby hemoglobin to the 20 to 30% range. And with that, the red cells become more stable, and they don't become sickle shape as much. And as such, their hemoglobin gets higher because less of the red cells are hemolyzed. And we know from both in clinical trials and in patients that taking a good dose of hydroxyurea really does reduce their pain crises, both in the hospital and outside the hospital. And if you have to be hospitalized, the number of times you're in hospitals are less, significant less, by these darker, the larger arrows. But over the last 5 or 6 years, there have been 3 new medications that we can use to treat sickle cell disease, and I highlight them here and to compare what they look like compared to hydroxyurea. The voxelotor or Oxbryta, as you can see, it doesn't change the sickle percent that much. It also probably doesn't change the fetal hemoglobin that much, but it does increase the total hemoglobin by 1 gram and sometimes 2. And what this medicine does is it reduces the propensity of the sickle hemoglobin to polymerize, and therefore making the red cells a little bit more stable and don't sickle as much. So we know that in patients and also in clinical trials, it increases the hemoglobin. But in some patients, I think it also can reduce pain. Take another medicine, L-glutamine or Endari, as some of you know it. Again, similarly, no change in the sickle fetal hemoglobin percentage or the sickle or the fetal hemoglobin percentage. There may be some increase in the hemoglobin, but that's really probably not as dramatic as the hydroxyurea or voxelotor. But in clinical trials, it has been shown to reduce pain crisis and hospitalization. Although many sickle doctors and hematologists would say that how it does that is still in discussion. But the extent of that reduction is not nearly as prominent or dramatic as hydroxyurea. And then the last medication, which is an injection medicine, as you can see here, is very similar to L-glutamine. It can decrease in pain crises in clinical trials, but I think in real practice, the effect of how much reduction that is still pretty marginal. So these are just the new medicines compared to the one that we know that we've known for the longest time. So how does the stem cell based type of treatment compare to medication? So I'll first talk about allogeneic, which just means that you're taking stem cells from another person rather than the person with sickle disease. And the idea is that you take the stem cells from a donor without the disease, and you give that to the patient. And I just want to go over some names a little bit so that we're all on the same page. You'll hear doctors talking about bone marrow transplant or stem cell transplant or hematopoietic stem cell transplant. All these just means that there are stem cells, which the definition of stem cell is being able to form other types of cells. And to make that more specific, a blood-forming type of stem cells, they all reside in the bone marrow. So when you talk to doctors or at transplant centers, we tend to use these terms somewhat interchangeably, although there are subtle differences between each of these terms. But for the sake of this talk, we'll just kind of consider them to be very similar. And the recipient is the patient with the disease. And typically for patients to go through this type of transplant, they need to have some moderate or severe disease, which we'll talk about a little bit later. But in general, what that means is they need to be hospitalized frequently. That means at least 3 or 4 times a year, or has some sort of organ damage complication that is difficult to reverse. And to know where you are, you should discuss your status with your doctor. And for this type of allogeneic transplant to work, you really need to find a healthy relative donor. And typically this is a sibling, and it's even better if they're from the same parents, or you can find the stem cells from a mom or dad. And whether the donor has sickle trait or AA, the transplant outcome is equally successful. And for the donor, they should go through some sort of blood testing so that they can find the most suitable donor. And how the process goes is that you collect enough of the blood-forming cells or the hematopoietic cells from the donor, and then we have to prepare the recipient. And I like to use the parking garage analogy here to prepare the recipient. And imagine the bone marrow of the recipient is the parking garage, and the cars in the garage are the blood cells, including the stem cells. So in order for the transplant to work, I got to first make space in the bone marrow or the parking garage. And then because the immune system of the recipient will recognize things that are not of self, so there's a need to reduce or lower the immune system, which are the guards to the parking garage. And how we reduce the immune system is by some combination of radiation, chemotherapy, or some other forms of antibody. Each transplant center has their own preferred combinations, but there are some common ones. And when you go visit transplant centers, you should ask them about what their preferred combination and what this transplants sort of outcomes are. And once you prepare the bone marrow of the patient, then you infuse the stem cells from the donor. And it takes about 2 to 3 weeks, sometimes a little longer, for the stem cells to take hold in the recipient marrow. And the hope is that when the donor cell starts to engraft or to make more of the donor cells, what they make is healthy red blood cells. And thereby, the sickle cell will eventually, the sickle red cells will eventually be replaced by healthy red cells, and the patient will no longer have sickle-related complications. And using the same sort of graphics that I showed before, where this is on the left side, sickle patients non-hydroxyurea, sickle patients on hydroxyurea, but as you know, you need lifelong sort of continuation of compliance in taking the medication. What the transplant recipients, their blood will eventually become just like whatever the donor has. If the donor has sickle trait, their S percentage is around 40%, where the remainder is, mostly hemoglobin A. And the hemoglobin, the number, goes up to 11 to 13, sometimes higher if it's a man. Or if the donor doesn't have any sickle trait or AA, you can see that there should be no sickle percentage in their blood, and they should achieve similarly high hemoglobin. And compared to taking lifelong compliance of hydroxyurea, typically this is a one-time intensive treatment, and you have to be on transplant-related meds for the first few years. And then you work with your transplant doctors to get off those transplant-related medicines. Sort of switching gear to now gene therapy. So allogeneic, the allo means taking stem cells from others, the non-recipient. Gene therapy often uses the stem cells are taken from the patient's own. And you can make modifications such as adding genes or changing certain genes. And the idea is that you take enough out of the patient's own stem cells out, you make some genetic modifications in some sort of culturing conditions, and then you have to give these genetically modified cells back to the patient. And why do we need this form of treatment? And the main reason is that for many patients, there are just no suitable donors, but they still have disease that's severe enough to get a transplant. So a little bit more of again the terms. I use gene manipulation to be fairly similar to gene therapy, and and there are different forms of gene therapy here. Because the sickle mutation is on the beta globin gene, one strategy is to add one or typically more copies of the correct beta globin gene into the stem cells of the patient to offset the 2 copies of the sickle hemoglobin. Or you can change existing gene to alter its production. And there are quite a few clinical studies now to reactivate the gamma globin so that they can reactivate the fetal or the baby hemoglobin. And the one that's still in clinical trial, still in development, and hopefully in clinical trials in the next few years, will be to fix the actual sickle mutations in the beta globin gene. And the process goes something like this. You still need to take enough of the blood-forming stem cells from the recipient, and these stem cells are sent to a manufacturing facility to undergo, the genetic manipulation that's in the clinical trials. But remember, there are still many stem cells that are left in the bone marrow of the recipient. And right now, how we're doing the transplant is that we still have to prepare the recipient, and that means mostly to make space in the bone marrow, even though there's no need to reduce or lower the immune system because these are stem cells from the patient's own source. And the main reason is that you need to give these genetically modified cells a better chance to take hold so that they quote unquote outcompete with the stem cells that are still left in the marrow. And how we prepare the recipient is that we still use high doses of chemotherapy to get rid of as much of the patient's own stem cells that are left in the marrow. And hopefully in the future, we will switch from chemotherapy to antibody-based, where they can just target the bone marrow. And the idea is still similar. These modified stem cells will eventually make healthy red cells so that the patients will not have ongoing sickle-related complications. And what this looks like, again, in the same schema, is that right here in the middle, rather than the 70+% of the hemoglobin S, it's that number is down to 50 or 60, and depending on the type of the gene manipulation, if it's gene addition where you add copies of the normal beta globin in, the A will show up here. But if it's to reactivate the fetal hemoglobin, then the F will come up rather than the A. And those that are currently in clinical trials, these are the rough numbers that have been reported in the literature and in the hematologic meetings. And as you can see, that the hemoglobin is pretty high, even higher than those on hydroxyurea. And and this is how you can compare them to the ones that are getting transplant from the allogeneic sources. And again, these are just one-time intensive treatment, And you do have to work with your doctors so that you can eventually get off some of the transplant related medications. So going now into, well, how do you know, when it's time to talk to your doctor about, should I be thinking about this? And I will start with, how is your disease, or where is your disease? What organs have damage from sickle cell? And are the medications or treatment that you're taking now working as expected? And you should know, or if you don't know, ask your doctors, what are your current lab results, and then compare to those schema or the pictorial graphs that I showed you, to see how well or not well your treatment is working. And then what are your life goals? And the answer to these questions will really help you to decide where you are in terms of the severity of your disease. Typically, we say that, you have mild disease, means that the medical treatment, whether it be medications or sometimes blood transfusion, is working pretty well. You rarely need to be in a hospital, and rarely means, probably 1 or 2 times a year or less. And that you're able to achieve or reach some of your life goals, if not most of your life goals. And then severe disease is that you have one, if not more, a debilitating complication from sickle, and such as a stroke, or you have a permanent or progressive kidney damage in an organ, and that could be in the kidney, sometimes in the liver or lungs. Or you have 3 or more organ involvement, with one of them where you need very frequent monitoring, like every couple months or even every month, so that the doctors are tracking whether or not they need to intervene. And if your status is not in the mild or the severe disease, you're probably here in the middle. And because the transplant type of therapy is pretty intensive, as I mentioned before, and it really takes about a good year out of your whatever you're doing in your life to go through that treatment. We generally say that the transplant type of treatment is for patients with moderate and definitely severe disease.
Dr. Hsieh, I just need to be the timekeeper here.
Yep.
We're at the 25 minutes after the hour mark. So if you could wrap it up in the next minute or so we can move on to the next speaker, please.
Yep. So I just have one more slide. So here are sort of some of the realistic expectations, for curative therapy. And I just highlighted just, 3 people, you have an 18-year-old person who is admitted, 2 or 3 times a year for pain crisis. But, despite being on a good dose of hydroxyurea. And for this patient, you could expect that, maybe the transplant would have a good outcome in that these acute sickling complications can be stopped. But, if you have a 35-year-old person with a lot of chronic pain and is admitted every month for pain, probably the chronic pain is complicated, and some of the pain will get better, but there's some pain that will likely persist after curative therapy. And if you have a 50-year-old person who had a stroke as a child, but is stable on medications and blood transfusions, but a stroke, which is a permanent organ damage, like joints or maybe in some of the other organs, these are probably unlikely to be changed by the treatment, the curative therapy. So, to know where you are and how they are likely to get better, you should really discuss with your doctor or doctors and the family, and then visit the transplant centers. So with that, I'll stop here.